it was logical to make the link between antibiotics damaging gut microbiome and the more broad spectrum antibiotics, such as amoxicillin, which it's probably our mainstay, isn't it, for prescriptions, probably cause more damage than the narrow spectrum antibiotics. The gut microbiome usually recovers in about 1 to 2 months.
What I say to my patients very often is, look, if I give you antibiotics prematurely where you don't really need it, they're less likely to work when you really need it.
I think if you give most people all the information, they'll make the right decision themselves. And, it's all about the consent process, isn't it? From me, was antibiotics are a very useful treatment that we have at our disposal, but we ought to be thinking twice before prescribing them.
Antimicrobial resistance, we see this everywhere. Scarily, it's already been earmarked as the next possible pandemic. That's how significant antibiotic resistance is. And what all the organizations they say is, as healthcare professionals, we need to be very careful when we prescribe these antibiotics, and we need to really make sure that there's clear indication to prescribe antibiotics. But we already know that. But it's funny because we live in this world where in some countries you can literally just go to the pharmacy, put some cash on the table, and you'll get some antibiotics. You don't actually need a prescription. And I'll tell you a little family secret. I have an auntie who, when she has a headache, she will pop an azithromycin for her headache. Just the one azithromycin, the one time. This is absolutely nuts. So, as healthcare professionals, what can we do? How can we decrease antibiotic prescription? Well, I think firstly, we need to truly understand absolute indications and when we should probably give it more time and just go with analgesics or other ways to manage that infection that do not involve antibiotics. And this episode with fellow Protrusive Dr. Jeremy Lennertz is a nice overview of when to prescribe, when not to prescribe, the impact on your gut of these antibiotics, and what we need to be mindful of as healthcare practitioners. Look, our job is tough. Sometimes your patient's absolutely begging you for antibiotics, and I myself have been in heated exchanges with patients. We show them a radiograph, there's apical pathology there, it's chronic, it's been there for years, and the patient's in some mild discomfort, and as soon as you say, look, there's an infection there, they're like, okay doc, give me the antibiotics. And then you have to kind of explain how this works and why antibiotics are not actually indicated, and then they think you're stupid because you just told them that you have an infection, why aren't you giving me antibiotics? And though that can get quite messy. So I'm hoping you'll be able to relate some of this and be able to come out a bit clearer on antibiotic prescribing. Now, every PDP ep, we give you a protrusive dental pearl. And today's pearl is all about making your life a little bit easier by giving you everything in a plate for when you need it. So we usually look at the guidelines, the STCEP, and there are a few others for antimicrobial prescribing. And what we've done is we've taken the best guidelines out there and combined them together. It's like a cheat sheet of all the true indications for antibiotics, all the interactions of antibiotics and other medicines, and what's your first line, second line, third line, the doses, the days, the whole shebang. If you're on Protrusive guidance, just scroll down, you'll see it there. We also put it in the Protrusive vault. If you're not on Protrusive guidance, please join us. But if you'd like to just go ahead and download that, head over to protrusive.co.uk/ABX. That's protrusive.co.uk/ABX to download our antibiotics cheat sheet. Let's join the main interview and I'll catch you in the outro. Dr. Jeremy Lennertz, so nice to have you on Protrusive podcast. You're a member of Protrusive community. It was nice that we sort of talked more about this kind of overall holistic care and some of the previous reading that you've done on this topic. And I'm just grateful that not necessarily as an expert, a specialist in this field, but someone who just is a day in, day out, wet finger dentist to talk about antibiotics and dentistry, and I really appreciate that. How are you, my friend?
Yeah, very well, thank you. Yeah, excited to be here.
Honestly, it's nice to see you. Like anytime I get someone from our community, it makes me feel so happy because I find that the Protrusive just really nice people to engage with. It's been really nice to speak to you on Protrusive guidance as well, and to finally have you here to discuss about quite a few things regarding to antibiotics and effect on gut and whatnot. But I just want to firstly ask about you. But tell us more about you as a dentist, your journey, your interests.
Well, I had quite a long journey into dentistry. I did microbiology at Cardiff University. Started in 1997. That was my first degree. And then from then on, I came down to Exeter University down in Devon, and I did a PhD in microbial ecology.
Wow.
Which, it's very interesting. Not great career prospects, really.
Well, you're a proper doctor, though. At least you're a proper doctor.
Well, proper doctor, I suppose, yeah. From then on, I did a short bit of research. I stood at Exeter, and then I had a job with a kind of instrumentation, a reagent kind of biotech company called Dacocyte. The career it wasn't working out how I'd envisaged it to be. I thought, what what changes could I make? And one of the things that I saw was actually Peninsula Dental School starting up. And so I was the first year through then. Yeah, the rest is history. Graduated in 2011 and pleased with career in dentistry.
So how old were you when you qualified then, if you don't mind me asking?
I think I was 31.
Okay,
yeah,
so
not
it's
ancient.
not too bad that you'd achieved so much, actually. But then what made you pivot your career from what you did to dentistry then?
Good question. I was so specialised before, kind of vulnerable career-wise. Like if something changes, funding or something, you have to kind of maybe change city, maybe change country to kind of get a job in your niche. That's kind of really why I made the change into kind of the industry, the biotech industry. And then there was just a lot of traveling there. To me and my girlfriend at the time were thinking, this isn't very good from a family point of view. So I was thinking, what could I do that's around everywhere? And always have a job in really. And then saw the sign for dental school opening in the area. So that
very good.
That was it.
The first cohort. That's very good to hear. And now, like when you look back at your previous career, you've been reincarnated. Do you feel as though it was what you hoped for? Are you able to have more of a family life or the kind of balance that you wanted?
Yeah, definitely. Yeah, I'm pleased with the choice. Yeah, I kind of love dentistry. Really interested in it. I suppose my clinical interests. I like a bit of aligner orthodontics. Bit of composite kind of cosmetic work. Apart from that, I'm just, general dentist, just trying to do kind of half decent job, really. There's a lot to be said for dentistry. You get paid well, don't you, for something you love doing. And it's a bit more stressful than I ever imagined. But
it's very interesting. I remember Sam Cope, one of the previous guests on here, who's also a guest on Dental Leaders. So he's a physio turned dentist, and he thought that the physio training was more stressful than the dentistry training, but now obviously he loves his dentistry and whatnot more than he enjoyed his physiotherapy career, so that's great. But when you compare your dentistry training to your previous like PhD and also your initial degree, microbiology, how do you compare the stress of the actual education aspect?
I'd say dental training was a lot more intensive, probably more stressful, I'd say, than previous education. And the PhD there's no syllabus. You just get given a subject area. This is the area you work on for your 3 years.
And with your PhD, I'm not surprised, but I'm just thinking in the back of my mind, were you not attracted or considering maybe specializing into oral microbiology? Did that ever cross your mind?
It did cross my mind. I thought, well, that would probably be a logical way to go. Maybe found it a bit boring, to be honest.
Good answer.
Again, I suppose one of the reasons why I left was become a bit less specialised, and I suppose that you don't want to re-specialise too much, really.
Well said. It was just something in the back of my mind. I knew I was speaking to you today. I wanted to just get that question out there. But our topic today that I want to discuss with you is antibiotics use in dentistry. And I think some of the messages that we want to discuss is how we already know that for irreversible pulpitis, antibiotics has no role. We know that already, okay? And then also when we see patients with infections, then we are still perhaps guilty, or as a profession, and I think it's been well documented, that we are perhaps over-prescribing antibiotics. And now more and more over the last decade, I've seen more and more come out about, especially on social media and stuff, about the gut health and the importance of that. And it's just another reason to be a bit more considered in our decision-making, in our prescription of antibiotics. So should we start with perhaps the background of antibiotic use in dentistry and the scale of it?
I mean, antibiotics in dentistry, they're a central part of our armamentarium, and they are a kind of a life-saving drug. You can't get away from that. Kind of most important discoveries of modern medicine. But here we've got on the slide, we've got about 10% of antibiotics globally. And around about that in the UK as well is prescribed for dental conditions. So, it's quite a chunk, really.
It's a whopping amount.
All things, it is. And the other bit of research looked at was 80% of these prescriptions are deemed inappropriate. So
wow. So 10% of antibiotics globally is for dentistry, whereas 80% of those potentially are inappropriate. So really, globally, dentistry should represent about 2% of antibiotics, not 10%.
Yeah. Assuming all other ones are appropriate. So, it should be much less than that. And I think we all know it from our daily experience as well.
Yeah, and I think we can have a real world conversation, right? Like sometimes a patient comes in and you got 10 minutes and they do have a swelling, and yes, we should be extirpating perhaps to try and or accessing the canals to drain the pus out from there, or we should lance it, but often the patients themselves, they come in demanding sometimes in very heated conversations. Like I've been in very awkward scenarios with patients, and I get really upset at myself if I start feeling flustered when I'm talking to patients, and I try and really keep zen and calm. But I just literally 2 months ago, Jeremy, I had to explain to a patient why antibiotics was completely inappropriate for his pain. He had acute apical peritonitis. There was no lymph node involvement. There was no pyrexia. And so have I prescribed antibiotics in the past for that? Yes, when I perhaps shouldn't have. But I'm now wise, and I think, you know what, in that scenario, I didn't think that was appropriate. And then to have that kind of conversation with patients and gets very heated, and they think you're fobbing them off. What are the? I guess what we should start with our younger colleagues. What are the true indications for antibiotics in dentistry?
Well, appropriate prescribing really is if there's kind of any signs of systemic or spreading infection. It's quite. There's not many situations where I suppose they are truly indicated. Yeah, and generally they should be prescribed as an adjunct to other methods as well. Opening up the pulp, just opening up the tooth, let it drain, lancing the abscess, local measures.
Let's talk about, for our younger colleagues, extracting the tooth, accessing the tooth to sort of drain the pus from the canals. But when it's a root-filled tooth already, how would you recommend? Extraction is one way, but what about incising the abscess? Yeah. Is that something that you commonly do?
I do quite. Yeah, fairly commonly, a few times a year. Nice sharp scalpel.
And in that scenario, then, if they've got that swelling and you've incised it and that pus come out, is antibiotics still indicated then as an adjunct, or the fact that you've got rid of the pus, is that enough?
Yeah, well, you really want to stop the pressure building up, and I would consider that to be enough for kind of treating the acute condition.
Mm-hmm, very true. And also, I guess the time to consider whereby antibiotics are really needed, just for our younger colleagues to understand is when I was earlier in my career, trying to understand the difference between an abscess and a cellulitis, right? And cellulitis, like when there's like a lot more widespread swelling and spread where there's nothing really to incise at. There's an infection you could see. And I think am I right in saying that that's a much stronger indication for antibiotics than just having a very localized abscess?
I would say so, because you haven't really the eyes closing or having trouble swallowing, then antibiotics would be appropriate, I would say. Yeah.
It's tough though, isn't it, for general dentists? Like imagine in public funded, where there's NHS in the UK or other countries. In some countries, you can literally go to the pharmacy and buy antibiotics very easily, right? And so it's a worldwide issue, but it's very, very tough because we know antibiotics can help in that scenario. But I think what we're going to address in the rest of this episode is, okay, so we know that overprescription is bad. Can you just summarize why the incorrect prescription of antibiotics or the overuse of antibiotics instead of local measures is bad?
It's not good for the individual due to its kind of effects on the gut microbiome, which we're going to go through later. Also, it kind of contributes to kind of antimicrobial resistance, both on a kind of a global kind of community scale and also on an individual scale. And then you've got the risks of kind of adverse drug reactions and allergies and anaphylaxis. What I say to my patients about antibiotics, I said, this is the temporary fix at best. It may not make any difference at all, especially if like the bacteria that are causing the infection are resistant to the antibiotic I'm prescribing it.
Do you audit antibiotics in your practice? I think we did. I'm going to pull up some data actually in our practice, but do you audit you and maybe the other practitioners if you're working with colleagues?
I probably prescribe antibiotics, I'd say once every couple of weeks on average. It's like buses, isn't it? Sometimes you go a month without prescribing anything. Sometimes it can be twice in one day.
And there'll be clinic colleagues listening right now and then be like, and some of our colleagues working in the front line, they would not be a single day without an antibiotic prescription, right? And it really depends on the demographic you're working in. Are you working in a pain clinic, emergency clinic, or not? And it will vary greatly. And so my antibiotic prescription is right down, very, very low. And more and more through experience, I'm feeling a little bit more proud of myself now having this discussion with you that, I'm a lot more sensible. I'm trying my best to avoid antibiotics for all the reasons that we're going to go into. You've touched on resistance at an individual and a global level, adverse reactions, as you say. But tell us more. I think I need to learn more about the actual impact on gut health.
So we know that there's a link between gut microbiome and mental health. And in poor mental health, you get increased levels of systemic inflammation, which is, well, pretty much bad for everything, but also bad for perio.
How could you measure this, Jeremy? Like, if I want to find out how is my gut health? Like, for example, I do my blood test like every 3-6 months, depending on what metrics I get, and I know my vitamin D levels, I know my testosterone levels, all that kind of stuff. How do I get an objective measurement of, where is my gut health?
There probably is no definitive measure of it. Like, I don't think science is there yet. Obviously, the Zoe company, that's probably as good as you're gonna get, I would have thought.
Oh yeah. When I asked you about your diet and stuff, is like, what do you think is the best diet? Just personally, like, what do you think is, like, there are people who are insistent on the carnivorous diet, right? And there are people who are very much like, okay, so you got to be keto vegetarian, be keto vegan kind of thing. And you see all that. I'm going to give you my take on this in terms of, because I'm interested in this field a little bit, but what do you do? What do you believe in?
I would say kind of less processed foods. That's probably a good thing. Lots of fiber and fermented foods. These foods are known as prebiotics. So these kind of feed the good bacteria in your gut. Yeah, as opposed to probiotics, which you hear a lot about in the marketing for
Yakult, right?
Yeah, things like that. I don't think. Well, there's very limited evidence at best for probiotics. I guess that they sell pretty well just with the marketing. So there's no reasons to do big expensive studies into them.
Very true.
Yeah, it's nice.
Down on the Yakult, more kimchi though.
Sorry, just a varied, healthy diet where you have plenty of fiber. Yeah, and fermented foods. Yeah.
But for me, I agree. And I think more and more, like, I read this amazing book recommended by Dr. Levine, one of our community members on Protrusive, Tom Levine. It was called Metabolical. I'm trying to think of the author's name, Robert something. And it was just, the theme is like the same as that book, Ultra Processed People. And it's all about just the damage that processed food is doing. So yes, absolutely eliminate processed food as much as possible. And I'm very mindful of that. It's very difficult feeding my children, it's processed foods are everywhere, right? So eliminate that, lots of fiber. And then like when it comes to like, should you be vegan, keto, should you be carnivore, like where should you be? I think if you're feeling good in yourself, if after you eat a meal, you feel okay. Like for example, when I eat pizza afterwards, I don't feel great. Right. And so I know that's a sign, right? When I eat a poke bowl, I feel amazing, right? So I eat nuts, I feel amazing. So listen to your body. And as long as you're pooing well, those three metrics, I think, it doesn't really matter which is the best diet because we don't know yet. Everyone will claim what's the best diet. So those are the kind of parameters that I follow.
That's good. Yeah.
And so on the topic of not feeling good, what happens when we introduce, someone's got an abscess, we give them antibiotics, they go home, take their amoxicillin. We might help them with their infection. And you know what? Their infection might have just cleared away after 2 days anyway, right? So we don't know how effective that actual antibiotic was. So that infection might have cleared away anyway. But what damage have we caused to the gut microbiome? And then why is that? Because obviously you said already how important it is for our general health, but just try and deliver that message home of the consequences of antibiotics on our gut microbiome.
Well, I mean, obviously, we've established the gut microbiome is pretty important, and antibiotics, by nature, kind of kill bacteria. So we're going to it was logical to make the link between antibiotics damaging gut microbiome and the more broad spectrum antibiotics, such as amoxicillin, which it's probably our mainstay, isn't it, for prescriptions, probably cause more damage than the narrow spectrum antibiotics. It usually the gut microbiome usually recovers in about 1 to 2 months, but it varies from individual, and it can take a lot longer. And the changes could be permanent.
What does that mean for the individual, though? So, as far as what we know in the research, like yes, all the bugs are changing. You're getting rid of some of the good bugs and the bad bugs. You're just clearing the dance floor, I guess. But then, what potential negative consequences could come of this from what we know so far?
Let's just pick a common one: antibiotic-associated diarrhea. I think it was called something different, but CDIL is the abbreviated name, and it's a bacteria which is commonly resistant to some antimicrobials, antibiotics. And so when you take the antibiotics, roughly 5 to 25% of people come down with this diarrhea due to the overgrowth of the Clostridium or Clostridioides difficile. And so that's just probably a really common example of the effects of antibiotics on the gut. Also, when we're thinking about kind of antibiotic resistance on the individual level, I mean, it'll be survival of the fittest for the bacteria in the gut. So you're wiping out all all the microbes, or virtually all the microbes that are not resistant to the bacteria, the antibiotic. And so you're developing like a community of resistant bacteria in your body. Also, under stress situations, bacteria kind of, they're more likely to share genes between each one. So you're more likely to get the transfer of kind of resistant genes from one bacteria to the other. Again, just really changing the community of the gut microbiome and increasing the resistance levels. How could this go on to affect you? Some stage in life, kind of quite likely to become immunocompromised. I've just taken kind of cancer as an example here. So obviously you're immunocompromised during a cancer treatment and probably get infections, and you'll be prescribed antibiotics to help with the infection. What happens if you're harboring a lot of antimicrobial kind of not going to turn out well.
And I guess going back to the previous things you said is that if we are having antibiotics and it clears the dance floor and you get rid of the bugs, all the benefits are down-regulated, and all the bad things about perhaps increased inflammation and the way that the bugs help us, we lose that benefit, I guess. But we don't know how impactful that is. So it's more like from the evidence that we have, like we don't know how bad exactly it will be long-term for someone for the antibiotics. I think we can agree that antibiotics are not great, but the whole inflammation, the mental health, the fact that the gut microbiome is important for us, and if we lose that from antibiotics, from the best of our knowledge, that's what we're losing out on. We're losing out on the benefits as well, and we're getting more of the bad stuff. Yeah,
so I guess we got a short-term gain from antibiotics for a kind of long-term pain, I guess. Undoubtedly, antibiotics need to be prescribed at some point. I think that's important, but we just need to be kind of very mindful that we might be doing kind of considerable amount of unknown damage to our patients.
If you just finish on a clinical point whereby acute apical periodontitis, patient comes in, the lower left molar is TTP, giving the patient a lot of pain for the last few days. It's negative to endofrost, so we know it's probably not pulpitis anymore. It's gone beyond that. We're dealing with necrosed pulp, but there's no lymphadenopathy, there's no pyrexia. And to make it a little bit more complicated for us, the tooth's already root filled.
Yeah.
It is so tempting. And I think I would say, hand on heart, probably most colleagues would, given the temptations, okay, you know what, antibiotics. And the patient will, when we see these patients again, oh yeah, I'm better now. But we don't know whether it was the antibiotics or the fact that inflammation that was there, it just settled because the body took over, and we don't know that. I guess the point I'm trying to make is the best thing to do at that point is either get in to remove the GP and dress it as best you can, which is laborsome, and not everyone has the skill to be able to do that, and might cause a perforation or whatever, or extract the tooth. And so we are in a very stuck scenario. Any advice you can give us in those very tough scenarios?
I would say the tooth's been root filled. It's got an abscess on it. Pretty much everything that can be done to the tooth has been done to the tooth, and so we've got two options really. We can take the tooth out, or we can kind of refer you for a re-root treatment. It's not guaranteed to work. I can guarantee it's going to cost you quite a lot of money. And I find most people probably just decide to have the tooth out, to be honest.
It's a tough one, but I think perhaps the role of just making sure they're on the right analgesics and to double down on that, and then find space in the diary to deal with it properly, right?
Yeah, and deal with it properly and quickly, really. There's some situations, third molars, things like that, or very anxious patients where you haven't got a chance, in which case.
There are people, Jeremy, you're going to laugh about this, or maybe you'll get a little bit sick hearing this, but there are people in my community, the South Asian community, right? Not very highly educated. Like, we literally migrated from Afghanistan. We came as refugees kind of thing. So the older generation, not very educated. And they will literally take azithromycin for a headache. Like, this is kind of the stuff we're dealing with, right? And so the importance of educating the public is just so important. And I think that's what it comes down to. Just sympathizing, empathizing with your patients. Like, I understand you're not a pain, okay? But what you're after here is not indicated. When it's truly indicated, then great. But just to calm them down, and you have to put yourself in their shoes. They haven't slept. They're not in the best frame of mind. But just to document everything, explain why you believe what you believe, and try to hold back the antibiotics, where possible. Sometimes the gun's against our head and it's just tricky. But I think if, as a profession, we reduce our antibiotic prescription, we'll be doing a good thing overall for our public health.
I think if you give most people all the information, they'll make the right decision themselves. And, it's all about the consent process, isn't it?
The word recommended is perfect, because we are allowed to recommend. And I recommend we go for ibuprofen and paracetamol here. What I say to my patients very often is, look, if I give you antibiotics prematurely where you don't really need it, they're less likely to work when you really need it. And if have you tried this? Have you tried that? And once we try down the strong analgesic route, if we then still need it and we see signs of it spreading, then I'm still here for you, kind of thing. And a lot of times, vast majority, they end up not needing the antibiotics. And so it can be tough. When patients trust you and they get it, then I think that's an important thing. So any last bits, with your background, microbiology, PhD, any last messages to our colleague?
I mean, I'd like, regarding your antibiotic prescription, just like to mention the SDCEP, kind of the Scottish Dental Clinical Effectiveness Programme. Because I
Scotland,
always use that.
The king of guidelines.
I mean, it is really good, yeah.
Yeah,
so,
right. SCCEP, we'll put the link to that. I think everyone should get that app. I agree. But
yeah,
I appreciate you also just giving very honest admissions. I think I have been as well. Like, we do this. Sometimes the clock is really against us. But the most important thing is, my friends, let's not ever prescribe antibiotics for an irreversible papaitis. Like, that is the worst indication for it, I think.
It is, yeah. And during COVID times, it was when we weren't seeing patients. I mean, that was awful. Yeah. The key message really from me was antibiotics are a very useful treatment that we have at our disposal, but we ought to be thinking twice before prescribing them and asking ourselves, are we actually doing the patient harm? That would probably be my key message.
So, Jeremy, you used to work in an access centre, I think you said. Tell us about that.
Yeah, so I worked in the Dental Access Centre, mainly in Exeter in Devon, for a few years. And saw a lot of kind of dental emergencies, probably more than the average, kind of firsthand. Lots of different variety, large facial swellings. And
do you remember how you would manage those really big facial swellings? Because when I was at Guy's, I used to work at ADC, like acute dental care. And I remember now and again, you get a patient with a really huge face. Like, I see about one a year in as a GDP, but in that hospital, we'd see one on a daily basis, right? Because of secondary, tertiary care, if you like. Hello, YouTube Protrusive. I know you're watching on YouTube, and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and is built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually, for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you do make an account on Android, iOS. If you make it on the website, you get access to the free trial and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description. And thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode. What was the management that you came across that was accepted at the time when you were working in the access center for those really diffuse, like cellulitis type swellings?
So I mean, if it's a huge swelling and it's very extreme, you've got quite a few facial swellings. I used to find that I would try and get the tooth out, even if they've got some trismus. My general rule of thumb was if I can get an ID block in there, then I could probably have enough access to take the tooth out. And that generally worked pretty well most of the time, because the tooth is the cause, really.
Which has been the theme of what we've been discussing today, really. But just to add, from the oral surgery consultants and registrars I used to work with, the way they would manage that scenario, I think the scenario you described, whereby sometimes we may need to send them to acute care, hospital, accident emergency, is when they're speaking really fast, like the hot potato voice, signs of real severe systemic spread, or they're having difficulty in breathing, like really quite severe life and death. Sometimes these patients would walk in, these blokes would walk in with a huge face, and they're kind of okay. It's still like, yeah, can I get this sorted, please? And they're breathing okay and stuff. So what they would do is from memory, they'd give like a bolus of antibiotic, like 3 grams straight away. And then they'd prescribe the amoxicillin and metronidazole dual therapy, basically. And then as soon as possible, they would arrange for the actual offending tooth usually to be extracted, basically. So that was the management then. And I don't think much has changed from speaking to our hospital colleagues, but just to, like, now when I see a really nasty swelling and for some reason we cannot deal with the source of the tooth at that moment, I would actually be going for dual antibiotic therapy, which I know goes against everything we're talking about. We're trying to prescribe less antibiotics, but the distinction of that really nasty fat face where you want to throw the kitchen sink at it, that's what I kind of remember from the registrars and consultants at Guy's.
Yeah, no, I've done the same thing as you, really. I mean, they just want to throw everything you've got at it, and say amoxicillin is not going to be effective, then you've got the metronidazole. But like you said, it goes against all that we've been taught. But sometimes,
just to have it up your sleeve, it's good. But what we don't want to do, I mean, the main message, as we keep banging on about, is you don't want to be giving it willy nilly. You don't want to give it for irreversible pulpitis ever. No, it's not going to do anything. Those are the basic things. How about like the timings, right? Usually when I prescribe amoxicillin or metronidazole, again, not very common nowadays, thankfully, but it's usually a 5-day course 3 times a day. I don't really deviate from that, and I don't know if I should. If it's a nasty infection, go to 7 days. But also the advice, I feel as though the advice has been changing and evolving. There was a phase where I read some guidelines that said that, if the patient's completely better at day 3, the old saying of, make sure you finish the entire course, perhaps that didn't apply so much anymore, and you stop at 3 days. I'm actually not sure what the best advice is now. Any idea on what is the best?
Not really. No, I just follow the Scottish guidelines, if I'm honest. For most of it, I'd go 5 days pretty much for everything. And I know for pericoronitis, the guidelines 3 days, but I generally just do 5.
I think if in doubt, guidelines are there. You can deviate away from them, but if you haven't found a good reason to deviate away, in terms of getting stuck with a patient and things not resolving, you're going to be more likely to get in some sort of trouble if you try to say, it says 5, but take it for 3, rather than take the whole course. It just, in terms of complete resolution at that point for that acute episode, it makes sense. But I do see the logic of the microbiologist saying, if it's going to work, then don't continue to take it. I get that as well, less systemic upset. So that's in the air. But I think your point of following the guidelines as best as possible is true. When someone has an abscess that we have to give antibiotics, and then it's not safe to give local anesthetic. If people are concerned, they justify it sometimes. Oh, we can't take the tooth out now. You have an abscess, and we can't possibly take it out while you have an abscess. We've got to wait for that abscess to come down, and then we take the tooth out. I don't follow that. I haven't been following it for years since my oral surgery experience. Tell us about your stance and what advice you'd like to offer to our colleagues who are listening, who may be concerned about injecting into an abscess site.
Get a lot of patients like, oh, I didn't realize you could take a tooth out. It's got an abscess on it. And, I'm thinking, that's absolute nonsense, because you're going to have an abscess on that, even if it resolves and becomes chronic, you're still going to have an abscess on you. So kind of quite a lot of the time, that's just an excuse to give antibiotics and not do the required treatment, in my opinion. So I would wholeheartedly kind of take the tooth out with an abscess on it, really.
Any different ways of anesthetizing here, in terms of, would you directly inject into the abscess or work around it, or what's the best technique in that scenario?
I mean, generally I try to give some kind of block. Generally,
and then also working around the abscess as well, right?
Yeah,
the abscess is buccal, going palatal, but also to the side, mesial and distal to the abscess.
Yeah, I'll go buccally, mesial and distal to the abscess. When the area is inflamed, I don't think there's any point directing inject directly into the abscess, because you're just going to watch it come out again for a start, and it's probably going to be painful, and it's not going to have much effect. But yeah, do mesially and distally. I don't know what you do, Jazz, but generally I do something called supracrestal. I don't even know if that's the right word, really, but the papilla, and you just kind of keep a kind of a firm pressure on the syringe, probably for about a minute, and then go around palatal as well. If the swelling's buccal, then you spend a bit more time putting it in the palatal. An oral surgeon showed me once, it's not very pleasant for the patient if they're not numb already. Yeah, just opens up the lumen of the needle a bit more, and then you can get a decent amount in palatally, and that helps quite a bit as well. I found you could have. I'm not bending the needle with my fingers, like you'd kind of just put it in and apply a bit of extra pressure. It kind of just bends the needle, and the lumen kind of, I guess.
Got it. So it's
opens
like
up from like the
so rather than bending the needle before you enter, it's like while you're in, you're then just leaning to one side maybe a little bit.
Yeah, that's right. Yeah.
Okay.
Otherwise, there's no room for it. But you can actually see the kind of the palatal kind of gingiva swelling there. But you wouldn't want to do that unless you needed to, because it's probably going to hurt afterwards. Well, I normally go probing around the tooth with my sharp probe, and sometimes you just go straight through the PDL, don't you, into the abscess, and then once you've done that, there's a pathway to the abscess. So I kind of go in there with my needle and try and get as deep down as possible, directly to where it's needed to get the most effective anesthesia, really. But it does that does hurt them a little bit, and but you're in the right place if it hurts. If that makes sense.
Yeah. When it's hurting, you're gonna be numb. But that's for sure. In my experience as well. In those scenarios where you have that abscess, and obviously you want to get rid of the tooth, which is the source of the infection, or get to the apex, for example, root canal method. You want to just get to the source of the infection, of course. Now, if there is an actual fluctuant abscess there, do you want to maybe lance it first to drain the pus out and then take the tooth out, or do you want to take the tooth out and let the pus drain through the extraction site?
I don't generally lance it first. It just happens.
Yes.
With the luxator or the forceps, and it just happens. Also, when you give the local anaesthetic, sometimes you can just see the pus coming out through the PDL.
One tip I'd give is that if ever in a scenario where someone takes out a tooth and they see maybe a little bit of pus release, but it's still there, I would at that point suggest, okay, maybe lance that remaining bit and drain it all out. A good saying is, don't let the sun set on pus.
Yeah, I've heard that before. Yeah, even after the tooth's out, sometimes you can get still the soft tissue containing the pus, but you want to kind of debride that. I think that's the right word. As much as possible, and get some drainage. What I generally do is I normally leave the patient while I'm writing my notes, and I get them to massage it as hard as they, and then I warn them for more bleeding afterwards, because the blood
it's inflammation goes part of that. Now, one thing I remember that confused me at the time is when it's more of a cellulitis and not an abscess, and there's nothing, like there's a swelling, the patient's face all puffy and swollen. but there's no like localized mass collection to actually lance into, and that's like a spread across the facial planes. And that one, you're not really going to get much pus when you take the tooth out, or there's nothing. So just bear that in mind. And rightly or wrongly, the oral surgery consultants, when it was more of a cellulitis, and let's say the eye was getting, the eyelid, they say the lower eyelid gets a bit puffy, classically a canine or something, that despite taking the tooth out, in those cellulitis cases, they were erring on the side of the caution and giving antibiotics. Now, I don't know what the guidelines say on that. It kind of makes sense when it's that kind of, it's very scary to see someone's face affected like that. But, to use your judgment, if it's a really nasty one, that could be something that could be part of that patient, especially if they're any degree of immunocompromised scenario, for example, especially if they're pyrexic as well and like systemically unwell. I think there's more than just that swelling. It really helps your cause and helps us justify what we're doing is the right pathway.
I mean, certainly at the very least, you'd tell the patient, if there's no improvement in 24 hours, you need to come and see me again for sure. I guess from my experience of that, normally they don't need to come back. And but also the swelling takes about 2 weeks to go down properly. If you found that as well.
I literally saw a patient yesterday who I reviewed. So earlier in the year, in January, he came in with like a huge golf ball. Actually, this might be November, so maybe like 8 months ago or something. So he had like a golf ball, like just under submandibular, huge, and probably bigger, probably a cricket ball. Right? It was huge, right? And it was from a lower molar. He went to oral surgeon, had the tooth out, and as that sort of infection all healed, his mouth opening has been affected only by a couple of millimeters, but when he's opening now, it just feels tighter on the left skin, basically. It is visibly, like, you could see the scarring and the fibrosis there. Really, it was a wake-up call in terms of, I don't often see that, but it was fascinating to see how much of a disfigurement and effect it can have afterwards if the healing process doesn't go so well.
Interesting story about my father. I took out a lower 8 on him, and it wasn't a difficult extraction. I don't know what happened, but he ended up with a dry socket. And
of course, it's your father. Family members, this always happens. It's 100% chance.
It gets a lot worse. This so he was because it's a 2-hour trip from his house down to my surgery. So I said, save yourself. Go to the access centre. They dressed it, gave them metronidazole, and it kind of resolved it. And then it got worse again. And I was like, oh yeah, it'll get better. Then it didn't really get better. It came down and did a OPG. All was fine. Sent it to my friend in oral surgery, and they said, "Oh yeah, that's fine." And then he ended up with this huge extraorally draining, I don't know, abscess on his face,
like a pimple, like a big pimple kind of thing.
Huge, and who knows? To this day, we don't know what caused it, but I think the diagnosis was probably like an infected sebaceous gland. And maybe caused by the swelling from the tooth or the socket. And anyway, we eventually went to he was back down in my neck of the woods, and whilst we were on holiday, took him down A&E, and they had a drain stitched in, but it drained for a couple of weeks, and he was on some antibiotics.
Wow!
But
so yeah, just like a facial drain, like coming out of his cheek.
Facial drain. Yeah,
just coming out his cheek. Oh my god!
Well, actually, it was a rolled up bit of glove that was stitched in there. So just keeping the glove was just keeping it open.
Wow.
Never seen it before, never seen it since. But that happened to your dad, didn't it? And anyway, so he's got his beard is totally grey apart from one area of black hair in the area.
Oh.
Strange.
It's like fresh growth.
I saw talking about systemic infection. I saw a great post. I think is it Sam Johnson, the endodontist from Wrexham area. Yeah, he did something great on Instagram recently. I'll just get it up. Let me put it down. The signs of systemic infection: fever, malaise, chills, and dehydration. Yeah, things that are warning signs: diffuse facial swelling, trismus, and difficulty swallowing, and things like that. These are the kind of things you want to look out for. You think that.
And going back to that diffuse swelling, exactly, the antibiotics. Yes, you can take the tooth out, but that element of diffuse swelling, in those cases, because it's a sign of a systemic spread, antibiotics are more justifiable than just a round fluctuant abscess, very localized to the area, right? That's a distinction we're trying to make here.
I think so. Yeah. I would say so. Yeah. And yeah, you couldn't even attempt to lance it, could you? Yeah, you definitely wouldn't do that. Do you know what's the maximum dose of articaine and lidocaine?
I have it. We have it as an Instagram post somewhere.
Well, I did a little bit of research last night, and there's no hard and fast rules really. 500 milligrams per appointment is the maximum recommended.
500 milligrams per
Yeah,
appointment.
so
Okay. But that 500 is
normally,
like, again, depends on their weight as well, doesn't it? Like, it's,
it
if
does,
it's
yeah.
a more petite person, it's a bit less. If it's a bigger person, rugby player, probably a bit more. So we've got the post here. Yes, exactly what you're saying is on our post as well. You do like a little calculation whereby if you have a 75 kilogram patient, the maximum safe dose is 330 milligrams based on that patient's weight, basically. And that's about 7.5 cartridges, basically. This is based on 2.2 mil cartridges. If the cartridges are 1.8 mil, there is 36 milligrams in that one, basically. So obviously it depends. And then with Articaine, for a 90 kilogram example, you can give about 7 cartridges. It says 88 milligrams of Articaine per 2.2 mil solution. Is that what you've got as well?
That's what my maths gave me.
Yes, so it's 2% lidocaine, 4% Articaine, hence why there's double the amount of actually the good stuff inside. So that makes sense. So actually it's less. 7 cartridges safely in a 90 kilogram person for the Articaine. Right, so actually, lidocaine you can give more, Articaine just a little bit less, based on that 10 kilogram sort of a familiar scenario we faced before.
Yeah, I suppose that we shouldn't really be approaching anywhere near that, though, should we? You might give, I don't know, 2 cartridges of each, and then if it doesn't go numb with that, it's not going to go numb, is it? Well,
I think it's more applicable when you're doing like multiple site surgeries, like you're doing full mouth of implants, and you're doing multiple blocks, and then there for several hours, and you have to top it up. I think that's when it really, then you have to really watch it. For a 1 or 2 tooth, even a quadrant procedure, you're never going to, you're right. Once you're done about 4 cartridges, you really have to think, okay, I need to try something else here because this is not working.
I remember my teaching was, dry socket is an infection, but bizarrely, metronidazole does help a bit. I mean, what I've been trying to do recently is just really never give metronidazole for a dry socket unless you think there's some kind of infection.
Systemic spread, as you said.
Yeah. It's difficult dry socket, isn't it? Because you want to do everything you can to help them because it is very painful, but the evidence.
I think that we discussed this once with someone on the podcast. It was Chris Waite, I think we discussed, where Alvogen used to be really good, and then they took out a really important part of the formulation, and they changed the name from Alvogen to Alveogil. So they changed the name by letter, right? So you might not, they're kind of fooling us a little bit here, so that it's not as good anymore. The good stuff that used to be in the original Alvogen is not actually in there anymore. But and so it may not actually be that effective. But the whole point of, I think, is that psychological thing that, hey, this dentist has done something, they put something, I will get better.
Yeah.
And it's a much better thing to put in someone's, sparingly, in someone's socket than giving them antibiotics for something that's probably not going to need it.
Yeah, and generally, I find patients do get a kind of quite a rapid benefit from Alvogen. And I've been thinking a little bit about, one of the questions from when we talked about this previously, like a person comes in with a root-treated tooth and they've got pain from it. It's obviously acute periapical periodontitis. What do you do in your very limited time of appointment if they want to keep the tooth? Because if they want to get rid of the tooth, that's fine. You know what to do. And I think realistically, we're going to give antibiotics in that situation. I think
that unfortunately in the real world, who's going to be able to remove the GP, get to the apex, and get to the source infection? So sparingly, hopefully, thankfully, it doesn't happen that often, but it is one of the more common ones that we see. I think it's to have a good look and look at the tooth as a whole. Like, has the tooth even got a fair prognosis, restorability-wise? Yeah. And if it doesn't, then why are we leaving that option of a re-RCT and restoring the tooth even on the table? Right. So if it's looking like, okay, there's the prognosis here is going to be poor anyway, maybe we ought to consent the patient more towards an extraction. But if it has got a decent prognosis for restorative prognosis and endodontic prognosis, then yes, sometimes it's not possible to get all the way down to a GP and to give the antibiotics to get them through this acute phase. But what I don't like is repeat offenders. Oh yeah, I'll get it sorted in the future. Every 6 months. Yeah, I have very limited sympathy for those scenarios. So I think I'm very good at encouraging patients. Listen, this is not good. Don't call me at Christmas. Don't call me Easter. It's going to happen on bank holiday. Don't even call me. So they get the point. Yeah.
It's going to happen on your holiday when you're away. Yeah, taking GP out and re-endos is more of a specialist thing, really, isn't it? I think.
Yeah, I don't think anyone expects you. I think that's a fair real world point made there. Well, there we have it, guys. Thank you so much for listening all the way to the end. Thanks for our community member, Dr. Jeremy Lennertz, for geeking out with us today. This episode is eligible for CPD and CE credits. We are a PACE-approved education provider. Just scroll down the app, answer the quiz, easy peasy lemon squeezy. Don't forget to download our antibiotics cheat sheet. That's protrusive.co.uk/ABX. And of course, if you're already on Protrusive guidance, we've got you. Just download it below. As ever, I'll catch you same time, same place next week. Bye for now.